Firstly, thanks very much to James for inviting me and getting me involved. I think James could pick up my sort of slight scepticism about this, and certainly some of the numbers we saw. And like anything, we said, well, let's go and have a look at the cases, and we'll see, whether this is something that's going to be useful. And I'm very pleased to say it's been useful, and it's been an eye-opener. And it's certainly changing my practice, and I'm hoping it will change the practice of my fellow consultants and colleagues in emergency, and then hopefully through the rest of town as well. There's some obvious reasons why emergency departments should be involved in this. I was sort of interested when I looked at the NELA data that the only group they didn't mention seemed to be involved with were actually emergency physicians. So they mentioned almost every other group of clinicians, including geriatricians, but no emergency consultants. So I'm pleased that James has rectified that here. And there are many reasons why we might be able to expedite care or improve care, and there are many reasons why we might get in the way and actually not improve things as well. These are some of the processes of care that were discussed in the NELA program. In particular, the one that's been most focused on, I think, is obviously the most direct for us, is prompt administration of antibiotics. But CT scans being reported by consultant radiologists, that's almost universally not happening in tertiary hospitals. It might be happening in peripheral hospitals, but it doesn't happen for us. And it's probably something we do need to work on, because I think in this day and age it's ridiculous that we don't get consultant reports on these sort of cases. And then obviously access to theatres without delay, and again that's about picking up the case early, making the diagnosis. And there are some other issues which I'll talk about later. It's going to be quite granular, I suppose, about what happens in my ED and the cases that we reviewed. These are some of the patients that should be getting very early antibiotics. When you actually look at the number of patients where really early antibiotics is required, it's really patients who have got septic shock or have got a high Q-SOFA score. These are people who clearly need very early antibiotics. I would suggest that some of the other patients that we see, it's less than 3 hours, because trying to get everybody with antibiotics in less than 1 hour, I think, is not going to happen, and it will be set up to fail. But there's clearly, but when we looked, even some of these patients were not getting early antibiotics, and it's clear from the audit that that's true as well. I think anybody who's got peritonism and looks unwell, has got any marker of organ dysfunction, clearly needs early antibiotics, and we shouldn't be waiting for the diagnosis or a definitive diagnosis, which is what seems to happen, before people give antibiotics. This is just the data from the PILA data, but I think the most telling thing is that even when you've got a Q-SOFA score of greater than 2 or greater than or equal to 2, which is by anybody's definition a really sick patient, this is somebody who's confused, and either they've got a blood pressure under 100 or a respiratory rate over 22, and yet we're still not giving them antibiotics, and some of them are getting very long delays to antibiotics. You're wondering, what are people waiting for? What do they have to declare? We reviewed some of the cases, or as many of the cases as we could get information from. We had 31 cases that I could review. About 9 of them weren't eligible for various reasons, the main being that they never came through ED, so we had no real contact with the patient. We had 24 that are eligible. 2 of them I still can't get notes for, so I'll follow them up eventually. 22 of the 22 patients that were reviewed, 13 of them didn't have any peritonism when they first came through the ED. As you'd imagine, most of these are people with adhesive disease, small bowel obstructions, where they didn't have dead gut. And most of them sat on the ward for 2 or 3 days and eventually failed conservative care, and then got their emergency laparotomy, or relatively emergent laparotomy, later. We did have 1 femoral hernia that did have a bit of dead bowel in there, but again she was completely non-toxic from that until the bowel was released. Unfortunately, multiple people decided not to examine her hernia sites, so even though she wasn't a major problem in terms of the sepsis and no antibiotics, she clearly defines what we find as a major problem, which is that we can't get juniors to actually go and look at groins. For some reason they seem to be averse to going into those sort of regions, and so we see these misses not infrequently. And then an indolent cholecystitis, and I'm not sure really, eventually somebody took out what sounds to me like a pretty cold gallbladder, but got there as an emergency disease. The patients that we should be really worried about are these ones, the ones that have clearly got peritonism on arrival. 2 of them were transfers, and both of those had really timely, well-organised antibiotics, so they came from somewhere else. And then we had 7 directs. 2 of them we did manage to get timely or relatively timely antibiotics into, but 5 of them we didn't. And 3 of them with duodenal ulcers. That seems to be a particular problem, so people with Perth DUs. And then two others, one basically both had ischemic bowel, one which was a direct ischemic bowel and another was an incarcerated internal hernia. The average time was about 4.5 to 5 hours for these patients to get antibiotics. Almost invariably they had been through a CT scanner first. 2 of those, that was because the patient, they had a duodenal ulcer which people had missed a small rind of gas under the diaphragm, and they were pretty subtle. So, but one of the patients was the one that had the SOFA score of 2 anyway. So, and she had a sore belly, and she had a fever, and there was no reason at all not to give this patient antibiotics. But for some reason, we had to have a definitive diagnosis before we cracked on and did something about it. I don't think Q-SOFA or signs of organ failure are going to be particularly helpful about working out which ones need urgent antibiotics, because so few of our patients actually meet that criteria. We had no patient who actually had septic shock, and only one patient who actually had a Q-SOFA score of greater than 2 or 2. The major issues we find are delayed diagnoses, and the people seem to be paralysed until they have a definitive diagnosis. And it's not just my junior staff or my colleagues that seem to be paralysed, but also surgical registrars that seem to be paralysed. That, until we've got a definitive diagnosis, what do? We just keep on doing more and more tests until we eventually something happens. Obviously, we've got issues with abdo x-rays and people doing proper exams and late CT ordering, which I think, again, is a problem because we're not getting, when we've got sick patients, we really need to get surgical registrars down there early, making decisions about what tests do they want next. Are they going to take them straight to theatre, or are they going to do a CT scan? Whereas we're often waiting to 3 hours until the surgical reg arrives and then says, oh, I'd like a CT scan now. And that's really delaying a lot of issues. The delayed antibiotic write-ups are really, again, as I said, awaiting definitive CT results, which is obviously ridiculous. And then I've talked about the late reviews. And also, often reviews by RMOs. So, we've sort of got a patient who's got obvious guarding and rebound and rigidity, and then the RMO comes down who can't make any decisions and isn't really of much use to anyone in that situation. So there are some issues. It's really been an education, I think. As I said, it's changed my practice, so I'm actively looking for the sick, abdo pains, if they've got any signs of sepsis or infection, they're getting blagged with antibiotics after they've had their blood cultures. And I'm hoping that I'll be dragging along the rest of my team to start thinking like that, not requiring a definitive diagnosis. If they look sick, and it's, I'm not going to be doing a P-POSSUM score for these patients, but the ones that it's clear that they could get into trouble, I'm going to be calling a surgical registrar early and suggesting that they come down quickly and actually put a hand on a belly and make a plan, not wait for 3 hours while my junior faffs around. I don't think we've had at least 2 cases recently, and we've had multiple other cases where the CT reports are changed by consultant radiologists either late in the day or the next day, where it makes a clearly major difference to the patient. We've had a piece of dead bowel that was stayed in a patient for 14 hours recently because of a changed report late at night. And it's just not acceptable, I think, in this day and age that we're not getting consultant reads for these sort of cases, or even the ability to ask for a consultant to read these cases. I don't think that emergency are going to do your P-POSSUM scores. I think that's a job for the person who might be going into theatre with the patient or calling their boss to talk to, and I think they need to be doing those risk assessments, but that means you have to come and see the patient and review them. But I think we can certainly call you and say we think this is a pretty high-risk patient. And obviously, at some stage, the college is going to need to be involved. I think both formally at a national level and also at a local level. Thank you very much.